This would be for people that are potentially interested in pursuing orthopedics, that you need to be incredibly strong or a jock to be able to do ortho. Not entirely true. You definitely have to have some strength to do orthopedics, but a lot of it is more technique rather than brute strength. And it's having a good team that surrounds you. So I would refute that as a requirement to go into orthopedics. So for any women or, other potential candidates that would be dissuading them from going into orthopedics, that's definitely a myth.
Hi, everyone, and welcome to Season 2, Episode 3 of The Breakdown with Rothman Orthopedics. I'm your host, Alex Hammond, and in the field of orthopedics, we know there are some common myths that have stood the test of time. So to help debunk some of those questionable myths and statements, I'll speak with Rothman specialist Dr. Meghan Bishop, sports medicine surgeon, Dr. Michael Hawks, trauma and fracture care surgeon, and Dr. Arjun Saxena, joint replacement surgeon. So I'd like to welcome in Dr. Michael Hawks. He is orthopedic trauma and fracture care and also serves as the orthopedic trauma medical director of the Advent Health Central Florida Division. Dr. Meghan Bishop, she's sports medicine surgeon specializing in sports-related injuries of the knee, shoulder, and elbow. And Dr. Arjun Saxena, joint replacement surgeon specializing in primary and revision hip and knee arthroplasty. So I want to thank you all for joining me. And as always, I'd love for each of you just to kind of set the scene and briefly tell your story, how you ended up at Rothman, and maybe specifically go into a little bit of your subspecialty as well.
Great, I can start. Thank you, Alex, for having me on. This is my first podcast ever, so I hope it goes well or reasonably.
Well, we love it already. There you go. We got to break you in somehow.
You're right. I do trauma. I did a fellowship in orthopedic traumatology in Baltimore, Maryland. And then for the last 13 years, been plugging it away in Orlando. If you see me, it's because you fell off a curb or got thrown off of monkey bars, or maybe something even worse that has caused you to have a broken bone of some type that needs to be addressed. And we are happy to take care of you. I became part of Rothman here in the last year as Rothman moved down their subspecialty excellence of care to the Florida market. And I saw a great opportunity to be part of something great. And so that's why I'm here.
Well, thank you, and welcome to Rothman Central Florida, and welcome to the podcast. Dr. Bishop, how about you go?
Thanks, Alex. Thanks for having me again.
Yes.
I'm Meghan Bishop. This is my second time on the podcast. I'm a sports medicine surgeon in Rothman in New York. So we have our offices in downtown Manhattan, as well as up in Westchester and Tarrytown and Harrison. I did my residency training at Rothman in Philly at Thomas Jefferson University. And then I did my fellowship in sports medicine at Hospital for Special Surgery in New York. So been there quite a few years now. We're quite underway, a little bit more so than Florida at this point. We've been in New York for about 3 years. Particularly a special interest of mine, I take care of shoulder, elbow, knee, all sorts of athletes, but I have a particular interest in treating female athletes. And I also see a lot of runners just as a special interest, as I'm a pretty big runner myself.
I feel like this is a huge accomplishment, not necessarily has to do specifically with your career at Rothman and even just as a physician, but you also, you say you've ran, but what did you do last year? You competed in what? Because that's a big deal.
I ran the Olympic trials for the marathon. Cool. And then I had a baby less than a year after, so it's been a busy time for me.
And you placed pretty high out of a lot, so congrats. I think that's awesome. So just wanted to share that. Dr. Saxena.
Hey, yeah, thanks so much for having me, Alex. So glad to be on here with Dr. Bishop and Dr. Hawks. Great to have you guys here at Rothman, too. So I am hip and knee replacement. I work in Mercer and Bucks County. Our offices are actually all in Mercer County in this division. And as far as being at Rothman, like Dr. Bishop, I had the opportunity to train at Rothman as well. And I'm very glad to be back here working as an attending. So it's been a great experience and my first Rothman podcast. So I'm very excited to see how it turns out.
Yes, and we're happy to have you. And again, I thought it was equally important just to make sure, specifically when we're talking about the topic of today, just to kind of get three different perspectives, three different subspecialties specifically. So, like I mentioned, we are going to hopefully bust some common myths in orthopedic care. So today we scanned the internet, which we all know is full of very reliable information. And we also kind of pulled our social media followers just for some common misconceptions that they've heard. And just, our hopes for today is that, the three of you can, provide further insight into the myths. So what I'll do is kind of like read a statement out and feel free to kind of just jump in with your thoughts. Even if there's like a little bit of truth to it or it's completely false, these are just the things that people were just interested in. Again, curious, just coming from the three different subspecialties and hearing everyone's thoughts on that. So if we're all good, then I'll just go ahead and we'll kind of jump right in. All right, so we'll start kind of very simple, kind of general orthopedic stuff right here. Knuckle cracking causes arthritis. Who has heard that? Or I'm sure, right? Is this a common one? Okay.
Very common.
So does it? Does knuckle cracking cause arthritis?
The arthritis doctor want to take that one?
Thanks for giving me that one, Dr. Hawks. I would go with no. I think, our joints all make noises. If you squat down low enough, you can have your knees make a little crack, and that's all normal. What exactly that is, I'm not sure. I've read some things that it may be some gases like nitrogen being released or moved from the joint. I'm not 100% sure, but no, cracking your knuckles, a cracking knee will not cause arthritis. Sometimes when we do have joints that make noises, it can be something that is a sign that we may have some early cartilage damage in our knees. But overall, cracking your joint does not mean you're going to give yourself arthritis.
Okay. I'm actually glad to hear that because specifically there's times when I take yoga and I forgot the one move where you squat and then like every time it pops. So it's good to know. Hopefully there's nothing serious going on there.
I would say when the cracking comes accompanied with pain, then maybe that's a reason why you want to get checked out. But yeah, like you said, we see tons of patients that have like kneecaps clicking and things like that. That doesn't necessarily mean there's something wrong. However, if it started coming with pain and swelling, then maybe you would want to get checked out at that point.
Okay. All right. Good to know.
As a dad of three, one of my kids' favorite things is for me to crack their toe knuckles on literally a nightly basis. And so I'm hoping it doesn't cause arthritis.
Fingers crossed. Worst case scenario, I guess you'll be flying up north to see Dr. Saxena or Dr. Bishop on that then.
Exactly.
All right. Next one. How about barefoot is the best way to walk? So meaning no shoes, just walking barefoot, especially around the house. I know I've kind of heard a few of our foot and ankle surgeons saying that they might, or even just, again, reading on the internet where they feel like people are just, because of the pandemic, so they're not wearing shoes as often. So potentially could be an increase in that. So just in general, like, obviously we're talking about the feet, but is walking barefoot good because it affects all your other areas as well?
Alex, I think this myth comes from like somebody wrote a book about shoe wear and running barefoot. Meghan, with your running background, have you ever heard anything like this?
I mean, I haven't really heard much about just walking around the house barefoot. But in terms of running barefoot, I mean, there are obviously some benefits to that. We can think back to a couple, maybe like 5 or 10 years ago when those kind of running shoes that essentially like fit your toes became popular to kind of simulate the barefoot running. It was a pretty big fad, and there were actually a lot of injuries that came from that for people. Lower extremity injuries, tendonitis. You can have more impact going through your joints, potentially be a little bit higher risk for stress fracture and things like that. So, I generally don't recommend using those types of shoes for runners. I think a little bit more stability, especially if you're doing more mileage, is beneficial. In terms of kind of just walking barefoot around the house, I mean, I don't think that's really good or bad. I think that myth is probably, something that doesn't mean too much either way. There can be benefits to it. I think of like helping with like stabilizations of the small muscles in the feet and building strength walking barefoot. But in terms of like causing larger issues down the line, I don't think that would lead to anything.
Okay. Does anyone else have anything to offer on that? since we were kind of, if not, I actually, just because we're on the subject of running and barefoot, and then immediately the next thing that comes to mind is running on the beach is the best surface to run on.
Well, that's definitely false. I mean, running on the beach is kind of miserable. I'm sure everybody would admit to that. I mean, you certainly
walking on the beaches.
Yeah, it's challenging.
Yeah.
I mean, the surface isn't great. Definitely can help lead to things like shin splints from changing surfaces too much. You could sprain an ankle, Achilles tendonitis, things like that. So, I mean, I think if you run on the hard packed sand, that's not quite as bad. But running on a slanted beach in soft sand is just not that enjoyable, and is a recipe for probably getting injured.
I'd have to add, as a father of 3, that walking beach with 2 beach chairs, 1 kid, 6 beach also is good for your health.
Great workout, though.
Confirmed.
You know what, too, Alex, is that when being down here in Florida with the beach and with a lot of people outdoors and running all year long, about 4 or 5 years ago, it was really common to be able to treat patients for lacerations of the plantar surface of their foot as well, because they were getting crazy. There was a lot of running without any real protection underneath their pads of their feet, and those types of injuries can be hard to recover from and to get back to the things you really like to do if you're nursing a laceration of the bottom of your foot.
Oh, all right. Dr. Bishop, as our resident runner, is there a surface that you would say is better to run on?
I mean, it depends. Softer surfaces obviously can be less impact on your joints, but I think it really depends on the person. I mean, I do all my miles on running on, pavement in Central Park, and I've been fine. But I mean, in people that are prone to injury, you might want to choose a softer surface, dirt or some kind of path, or even on the track rather than running all on pavement.
Okay. How about this one? If you can walk on it, then it's not broken, or use it.
Yeah, I don't think there's much to that myth either. I think that's also false. You can certainly have a broken bone, and it might not be displaced or it might not hurt that bad, but continuing to function and use the limb would likely make the situation worse. I think that if you have injured yourself and you in any way is suspected to be something that's going to last a day or 2 longer than you wanted to, then I would probably see a physician to be able to do a appropriate clinical examination, x-rays, make sure that you can get back out and do the things you want to do and not have to worry about the long-term effects of avoiding treatment and evaluation.
Yeah, I couldn't agree more with Dr. Hawks there, Alex. And, we see this all the time, that people have an injury and they think nothing of it, and they show up a couple weeks later because they either had a tough time getting an appointment or they thought it was nothing. And that's really part of the reason why we've established, urgent cares in some of our markets. That's just a quick way to get, evaluated. And we have x-ray machines in our offices, and we can really, kind of put these issues to bed or diagnose them if they're really issues pretty quickly for patients. So that's something that we really try to offer the community.
Yeah, I mean, I immediately just I think of, let's just talk football since we're kind of in the peak season right now, but seeing, there's nothing worse when you see a player go down and then, the announcer will say, oh, great, they got off the field on their own weight and, that's great. And you're kind of feeling hopeful. And then you kind of find out the next day, or even if they went back in, then it's they torn ACL. Obviously it's not broken, but something, is that kind of a similar thing too? Maybe with knee injuries, or is that kind of the same thing? Just because I can walk on it doesn't mean it's not worse than I think it is?
I'm going to defer to Dr. Bishop, the sports expert on this one, but I think the perfect example we have is right here in Philadelphia. Carson Wentz tears his ACL and then goes and scores a touchdown.
Right.
And then, the rest is history. But, Meghan, what do you see in the sports clinic?
Yeah, I mean, I think Donovan McNabb did the same thing. I think he played a couple plays after he tore his ACL as well. So, I mean, adrenaline does a lot when you're on the field. So it certainly can carry you through pain and be able to play through injury without really feeling it as much. But A lot of times after these ligament injuries and things like that in the knee, people can actually walk initially. It becomes a little bit harder once the knee swells up later after the injury. So, just because you can see a player, walk off the field doesn't necessarily mean they haven't done anything too bad, unfortunately. So, in terms of kind of the initial question about if it's broken, can you walk on it or not? In terms of what I've seen a lot recently is with the New York City Marathon, and a lot of runners running that. Stress fractures are something that I think of too. And I actually saw a lady that ran the entire New York City Marathon with a femoral neck stress fracture, and saw me 3 days after, and been having some groin pain for like a couple weeks leading up. And she was very lucky it didn't complete during the marathon. So you certainly can run on a fracture. If you are feeling those symptoms of like weight-bearing pain, even pain at night, like when you're lying in bed, those are kind of signs that you definitely should get checked out and at least get an x-ray, if not an MRI.
All right.
Yeah. And Alex, sometimes what we probably deserve some attention to are hand injuries. And so, if for sure you're not walking on your hands, and so you might just leave it alone if it looks a little bit red, a little bit displaced, or a little deformed, and you say it's going to get better, it's just a jammed finger. And what can happen over time is that it might be an articular injury. It might be something where the joint of one of your fingers is broken and heals in an improper way. And the hand is a lot less forgiving than some of the other areas of your body when it comes to function. And so a lot of those structures around a broken bone, around a deformity, can then become scarred area that would be very hard to correct and get back to full function.
All right. Great. Thank you for that. Next one. This one's a little bit targeted, so I'm sure the right person will know the answer to this. But young people do not require total joint replacements.
All right. I'm guessing that one was for me.
Possibly.
Yeah. As a joint replacement surgeon, what we do is we want to take people who have, severe arthritis and allow their joints to function more normally. A joint replacement's never going to be as good as your knee was when you were 30 or 40 years old. But if we can get people to walk without pain, that's ideal. Now, you're asking about young people and joint replacement. The youngest joint replacement I've done, I believe, was a 28-year-old I did a hip replacement on. And so that sounds really young. The majority of our patients are going to be, over 60 or at least over 50. But you can get medical conditions, or some people who are just really unfortunate to have some severe arthritis at an early age in people in their 30s or 40s. One of the more commonly known ones is avascular necrosis of the hip. And that's a condition in which the blood supply to the femoral head, the bottom part of your hip joint, but the ball part of the ball and socket joint, dies. And when that blood supply dies, basically the bone sort of collapses and dies. And you end up with having this ball in this socket to instead having this kind of amorphously shaped piece of bone that's not really healthy and is causing severe pain and dysfunction. So that's a condition that pretty commonly, if someone's in their late 20s, early 30s have it, we will do a hip replacement on a young person. And sometimes, I actually have a patient who was 45 and just had horrible knee arthritis. He had some trauma when he was younger to his knee and actually had some surgeries. And at some point, it becomes a quality of life issue. So
right.
For those patients, they likely will need some type of revision or secondary procedure in the future. We want them to have quality of life now. And so it's reasonable to do a knee or hip replacement in a younger person. And when I say younger, I mean someone in their 20s or 30s or 40s, if their arthritis is severe enough and it can help their quality of life.
Actually, I kind of want to link the two. So when I think young and just kind of, again, just some things that I've heard, I automatically kind of think of like the young, the active crowd, the athletes. So Dr. Bishop, is there ever a time where potentially you'll see patients, again, if they're having any hip or knee issues that are so bad that you could potentially, refer to a joint replacement specialist because it just may need to go that route? Have you had any of that experience or heard of that?
Absolutely. There's different types of arthritis or cartilage injuries we see in patients. I generally treat the more focal cartilage injuries that are, only to a specific compartment of the knee or a smaller area. Those are patients that can generally sometimes be treated with cartilage restoration type procedures to get them back to function. Other things we look at, if it's just on one side of their knee, occasionally we can perform something called like an osteotomy, where we actually realign the knee joint to be a joint preservation type procedure. However, for patients that have more kind of diffuse arthritis throughout the whole knee, even in young patients, I would send them to an arthroplasty surgeon for evaluation.
Awesome. Anything, Dr. Hawks, you'd like to add to that, or your experience or that you've seen kind of in the trauma in the OR?
Well, there have been some patients that had such a bad injury to one of their joints, even though they were very young, that we can treat with surgery to realign the bone, but we can't really do too much with the cartilage damage. And so if that gets worse over time, patients may be too young, let's just say, for total knee or a total hip in some people's eyes, but certainly I would be referring them on to someone like Dr. Saxena for taking care of that pain and that dysfunction to get them back on the road.
Awesome. Kind of want to stay in your wheelhouse, but so you have to have some sort of big fracture or car accident in order to be treated by a trauma and fracture care surgeon. And I guess kind of what I want to get from you is, because immediately when I think of trauma, like I think it's got to be like the worst case scenario for them to end up. And like you said in your intro, you're like, you could fall off a curb. Right. So right. I guess I kind of debunked that myself, but if you can just kind of elaborate a little bit more of kind of what comes through your doors.
Sure. Well, I mean, a lot of us as orthopedists take care of patients, whether or not they're chronically or acutely injured, that have sustained trauma in some way. That's a change in their life because of something that happened, right? And so patients all the way from like I was just mentioning, there's a small finger fracture all the way to a significant pelvis or hip socket fracture may come through our doors. And we treat all comers. And I would say that if you, again, what I said before, if you have an injury, you're worried about it, the best thing to do is see your physician, get a good exam, get some x-rays, make sure that you're not missing something and we can take care of it. The worst thing you can do is not get something treated that could have improved your long-term function.
Great. All right. How about you only need to see an orthopedic specialist when you're hurt or there is an issue? Dr. Bishop, I'm going to probably toss this to you because I feel like...
So that is not true.
Okay.
Especially as a sports medicine doctor, we generally, with our non-operative sports medicine partners, kind of take care of, the whole athlete and the whole person. So we'll frequently see people, for performance type issues, not necessarily just be an orthopedic injury, just kind of optimize performance, getting patients to be able to be themselves in their athletic performance and things like that. So I would say that is false. I mean, I definitely see patients that kind of come in for social visits too, some older patients that just get their knees injected frequently for arthritis or something like that. And, want to just check in every few months just to make sure they're headed on the right track with that. So, you don't necessarily always have to have an orthopedic problem to come in. I think it's good to sometimes get just an overall evaluation of your health, and that can be done through either one of us or through one of our non-operative doctors as well.
Dr. Hawks, you're kind of like the complete opposite because you literally meet patients when?
Yeah, something bad has just happened for them, for sure.
Right.
And usually they get to us by way of either, a trip to the ER or a cab ride to the ER, either in an ambulance or a helicopter, for sure. But the good thing about working for Rothman is that it's such an amazing ability to, if a patient goes to the ER, if they go to our office, we're able to put them with the right doctor. And so, like Dr. Bishop was saying, sometimes it doesn't mean seeing a joint replacement surgeon. Sometimes it doesn't mean seeing a traumatologist. It might be one of our non-operative sports physicians who can prescribe the right type of treatment. It's on non-operative, minimally invasive, if anything at all, and get patients going the right direction.
Awesome. Thank you. All right, next one. Again, this is super targeted, and I'm going to lead you a little bit, Dr. Saxena, but when it comes to joint replacements, robotics is the best option. And this is something I know you probably get a lot. I know we always hear, people hear that and they automatically assume this is the best thing. I'm saying robotics, but we can just talk about technology in general. Like having a physician or a surgeon who uses technology is better than someone who doesn't. So I think, if you don't mind.
Yeah, that's one we do hear about a lot. Orthopedics has changed. I was actually just at the American Academy of Hip and Knee Surgeons meeting this weekend, and I commented to someone how much things have changed in a short period of time. 5 years ago, really a very small percentage of people were doing robotic joint replacement. Only one company really had a mainstream robotic platform. And now actually all the major companies and even some minor companies have a robotic platform, and it seems to be much more common. But what's interesting is that we haven't found is that there haven't been a ton of great studies showing superior outcomes using robotics. And the one thing people need to understand when we talk about robotics, this isn't R2D2 coming into the OR and doing the surgery with his computer eyes, right? These are basically tools that the doctors can use to achieve results that they want, whether it's an alignment result, like if they want a straight leg, or a certain balance they want of the knee or something like that. So, or even for a hip, a certain position of one of the components. So these are great tools that can help surgeons to be, more accurate. But interestingly, when we've studied it, robotic versus what we call manual or traditional instrumentation, we haven't really seen better outcomes. So no, I would say that would be a myth that robotics is better. But I do think whether it's robotics or navigation or any technological tool a surgeon uses, it can just help that surgeon to achieve the outcome they desire. Now, some people may always want to use these things. Some people may use them sometimes, and some people may use them never. I'm in the middle. I actually did 2 robotic partial knee replacements this morning. And tomorrow I'm going to do 2 knee replacements with just manual instrumentation. And I think all 4 of those patients will do fine. I don't think there'll be any difference. So no, definitely a myth, but it is something that's becoming more common. And what I usually tell people is, look, just ask the surgeon, whatever you do most often and whatever you're most comfortable with, just do that. And so if it means that I'm a surgeon who just does all of my knee replacements with the robotic assistance, or if I'm a surgeon who does all of my hip replacements with the traditional instrumentation, or the majority of them, then just let them do that. And that's really the key, I think. And that's one thing I feel like, we talk about, how do you pick a doctor? And I think the number one thing you can do as a patient when you pick a doctor is just, find a doctor that you trust and just let them do what they need to do. Now, unfortunately for Dr. Hawks, they kind of have to take who's there because they're sort of showing up in but fortunately for them, the trauma team down in Advent is very trustworthy and proficient. So they should be fine if they end up in the ER and they see Dr. Hawks looking at them.
Absolutely. So again, just to kind of summarize what you said, so it really is just, there's not one way, like somebody who does manual versus robotics or any other sort of technology. It really is just based on a preference type thing. Not one way it's just all dependent on the surgeon themselves, right?
Yeah, absolutely. And a lot of Rothman surgeons have been in development of a lot of these technological advances. And so we're constantly trying to study them because we are constantly trying to figure out what's the best thing for our patients. But I think what we found thus far is there are different ways to skin a cat, and there are multiple ways to perform a technically sound and a successful knee or hip replacement.
Great. Does anyone kind of just have anything, Dr. Hawks or Dr. Bishop, just generally speaking, like is in technology, like is there certain procedures or, that could be used with some sort of device versus the other way? And again, does it, kind of fall in the same lines as the, robotics versus manual? I don't know if there's anything specific in your specific subspecialties that you can kind of relate to this a little bit.
Well, we don't use robotics for shoulder arthroplasty, but we do have kind of VIP preoperative planning that we can use. So it's essentially you can put the patient imaging into a computerized system, and you can plan for patient-specific guides to be able to show how you're going to make your cuts for the surgery and the exact sizing of the implants, and they're kind of created just to be specific to that patient or the anatomy of the shoulder. So that's been a pretty useful thing for shoulder arthroplasty for us. However, like Dr. Saxena said, there's been no studies that show that using that is superior to kind of just general, arthroplasty and making the cuts, but it definitely is helpful for the surgeon, at least going in, to have like a game plan. Mm-hmm. You can go over with the patient exactly where their cuts are going to be even before the surgery. So it's been a nice tool to have.
Awesome.
And for trauma, advanced technology is just starting to dip a toe into some of the things that we do. And so, like the 2 other surgeons mentioned, It's just getting to know the surgeon, trusting him or her, and being able to appreciate what they do and what they do every day.
So Dr. Hawk, you guys were saying in Orlando, you guys, there'll be 2 guys running the OR at the same time?
So today, Atif had the day off, I think. And so our third partner had 2 rooms and I had 1 room. And then we just file them in, and, whoever has some free moments, they get in the next case. And we do that all day long. And so generally it's somewhere between 10 and 15 cases or so on a daily basis that we'll get through. I was able to get through, help my guy out with about 6 cases, and then got home around 2 or 3 today. So we got a really efficient OR and folks that just do that all day long. So it's nice to be able to get through a day like that.
Yeah, that's amazing.
Yeah, that's
quite a team down there. You guys are doing awesome.
Oh yeah, and Atif has really gotten to be quite a very productive member of the team as well. And he's doing great.
Good.
He puts together some quality work for sure.
Yeah,
and now a lot of it.
Good.
All right, so I have a couple more before we kind of wrap up a little bit. So again, this one's a little bit more targeted, but going kind of back to is running is bad for your knees and can lead to arthritis. So I know we kind of touched on that a little bit with the knuckle cracking, but what about running and knees and joints? How about
Megan, am I correct? Did you guys put a paper out on something like this?
Yeah, actually, Dr. Ponzio down at Egg Harbor was the lead author on this. But that study specifically looked at marathon runners and tried to associate long distance marathon running with the risk of increased osteoarthritis. And they actually found that marathon running was actually protective in a lot of cases. So, which is totally counterintuitive. So what a lot of people think. There's a number of reasons for that. Sometimes these people, a lot of that is self-selection. So these people that can continue to do these many miles are probably going to have better knees genetically to begin with. But I actually gave a ground rounds on this topic a year or 2 ago. So running itself is actually can be protective of your knees, in moderate amounts. So, the people that are running, the elites running 100, 120 miles a week, that's not protective of your knees. That's overdoing it. But moderate amounts, 10 to 15 miles per week, can actually be good because loading of your joint is actually good for the cartilage. Unless you have some kind of, previous traumatic injury or pre-existing arthritis to the knee, then those are reasons you don't want to be going out and running marathons. But in general, running can be good for your knees.
Yeah, that was a really well done study by you guys. One other study that they kind of sort of alludes to that topic, Alex, is weight. And I was kind of researching at one point, how do people develop arthritis? How do we prevent arthritis? How do we prevent knee replacement? And there were some studies I came across from England, and these were, I guess they were kind of people in northern England. And I guess there, the population's pretty stagnant, so people don't move. So they're able to do very good long-term studies. And what they found was people that are even 10 or 15 pounds overweight in their 20s were 3 to 4 times more likely to get knee replacement in their 50s. So I do believe that there's a pretty direct correlation to weight and the development of hip and knee arthritis. So what I would tell people is your key to not developing arthritis would be weight control.
Right. And that's a great point too. I would definitely, that's a main finding as well. Maintaining a healthy weight is going to be the long-term, that's the best thing people can do for their knees. I always tell my patients, an extra pound overweight is 4 pounds on your knees. So it's something to think about.
Right. And it's really hard for people like me because I love Sour Patch Kids. But yeah, you got to keep that weight under control. That's the number one thing. And I think that it's a little off topic to your question, Alex, but I think
no, it's relevant though.
Maybe the people that are running are controlling their weight a little better than the people. So maybe that's why running's also a little protective.
Okay.
And we're just orthopedics, so we don't really care about the heart and lungs, but those probably do a lot better when you're running and you're a little on the thinner side too.
Only care about your joints here, right? All right. So I have one final kind of myth, and this one I think it's perfect for all 3 of you to answer. But So seeing a general orthopedic specialist is better than a fellowship-trained subspecialized physician. Thoughts on that?
Is that a myth? Is that a myth that's
I
out there?
mean, listen, well, it's not necessarily a myth, but there are people that will see a general orthopedist versus, going to someone who kind of just hones in on one thing. So what would you say to them if that's the case?
I think people have a right to their opinion, and I think it varies. And I think that, we have some orthopods. Actually, one of our senior joint replacement surgeons actually never did a fellowship, but he's done more joint replacements than many people in the country. And he's excellent. And so I think that it's great. And I think the Rothman model is fantastic that we have, people that are really focused in a couple of areas or one specialty. And I think that does lead to better outcomes. That being said, I think there are a lot of people out there, whether they have a fellowship or not, who practice general orthopedics. And I think that they can also help take care of people and do well. And I think, again, it really sort of comes down to your comfort and trust level with the surgeon once you meet them. And that's really the key. And I think there are plenty of studies that show that if patients trust and are comfortable with their surgeon, compliance to treatment recommendations, whether it's a pill, whether it's therapy, whether it's a surgery, are going to be higher. So I would say that, we have a great model here where I would say over 90% of our surgeons are fellowship trained and stay within that fellowship. But that being said, I think that, just because you didn't have a fellowship, or even if you're doing something that may be outside of your fellowship, doesn't mean you don't have talent and capability there.
Very well said. Does anyone else have anything to add?
I completely agree with Dr. Saxena in that there is the opportunity for a generalist to be useful as well as a subspecialist. I think that I really like being a part of the Rothman model because you are going to be sent to the surgeon that does that particular procedure all the time. And like he said, I think that leads to overall better outcomes. The very fine point of something that Dr. Saxena said is that there is a senior surgeon that does a really great job of joint replacement surgeries. I'm sure that he or she, even though they're not fellowship trained, they do that on a daily basis. Mm-hmm. And I think that if you have somebody that maybe does one or two procedures once or twice a month, I think that maybe that would be harder for me to buy into as if they did many of the same procedures every month.
I completely agree with Dr. Hawks and Dr. Saxena. The more you do of the certain cases, the better you're going to be and your outcomes are going to be better. And not only, with people being hyper specialized and fellowship trained in certain subspecialties, it's not just performing the surgical procedures. We're also performing research in these areas as well. So that really helps kind of fuel our patient care too.
Awesome. All very well said. So just to wrap up, kind of give you all the opportunity. Do you have any last words, or is there any myth that we did not talk about that maybe grinds your gears a little bit, or that again, that we didn't kind of talk about here, or that again, that you hear? Feel free to throw it out there now.
One thought that I have is that I've made it through my first podcast and I'm so proud of myself.
Great. Did Dr. Ahmed give you any pointers?
He did. He's a great speaker. But the second thing that I'll say is that sometimes it's hard to be able to explain to patients that have been treated with surgery for a broken bone that they are not healed the same day that they are fixed. That we do a really good job of realigning the bone and putting it in a place where their bodies can do what they do best and to heal in the appropriate position. But it takes a lot of work through the therapist, through their own self-directed care, and to being a little gentle on that fracture before it heals, before we can give them the seal of approval.
That's a good one. That's a really good one. I didn't even think about that, because I think you're right. Seeing people, just their frustrations, and they think you're right. We get the surgery, and maybe it's a little bit different with you, Dr. Saxena, but you're some of your typical cases, Dr. Hawks, I'm sure, great, the surgery, I'm going to be walking or doing whatever back to normal, and just not really understanding or knowing that, it is a long process. So that's a great one. So thanks for bringing
No,
that to the table.
it's the same for us too. Dr. Hawks, totally agree with you. It's a process, and you can come to our office and we can get you better, no doubt. But it's probably not going to happen on your first visit. And if you need therapy, it's going to take time and effort on the patient's part. If you need surgery, it's going to take time and patience. So, yeah, these things are always a process. We have outcome scores that show that people continue to improve after hip and knee replacement for up to 1 or even 2 years. So when you call and feel frustrated that you're not better 2 weeks after surgery, yeah, you got about, 102 weeks left.
22 months.
Yeah. Your maximum improvement. That being said, we all understand that, these aches, ailments, whether it's a broken bone, whether it's arthritis, whether it's a torn rotator cuff, these are limiting patient's function, and it's frustrating, and it's just really tough to get through, but it's always a process, just like Dr. Hawk said.
Awesome. Thank you.
I have one final myth that I can contribute to. This would be for people that are potentially interested in pursuing orthopedics, that you need to be incredibly strong or a jock to be able to do ortho. Not entirely true. You definitely have to have some strength to do orthopedics, but a lot of it is more technique rather than brute strength. And it's having a good team that surrounds you. So I would refute that as a requirement to go into orthopedics. So for any women or other potential candidates that would be dissuading them from going into orthopedics, that's definitely a myth.
That's a really important one. We actually had a whole symposium this weekend at the hip and knee meeting about diversity. And, part of that is, minorities participating in orthopedics and becoming orthopedic attendings. And the other part would be females. And so that myth is that it's a bunch of guys in a call room. It is not true. And, I'm really proud of the Rothman residency program here in Philadelphia because we've had a lot of really strong female orthopedists come out in the last 5 or 6 years. And it's a great thing. And so, it's good to have diversity out there, whether, it's based on race or ethnicity or sex, just because then the more people are going to feel comfortable seeing. Sometimes people like to see somebody that's kind of like them, and so more people will seek care, and more people will get better. And so, Meghan, I think that's just a great point, and totally agree with it.
Yes, thank you. Leaving a little something. I know obviously this is very patient focused, but for the for future surgeons, hopefully at Rothman, thank you for that one. But I would like to thank all three of you, Dr. Saxena, Dr. Hawks, and Dr. Bishop, for joining me today. This was great. I mean, I kind of did this stuff for myself too, because it's, again, specifically the knuckle cracking, the knees, popping, all that fun stuff. But this is a great episode. I know people will really appreciate it. Again, three of our finest surgeons, in Florida, New York, as well as in South Jersey, Philadelphia, that area. So again, thank you all for joining me today.
Thank you so much. Great to be on, guys.
I'd stay longer, but I have some knuckles to pop.
We'd like to thank Dr. Saxena, Dr. Hawks, and Dr. Bishop for joining me on this episode. Please visit our landing page, rothmanortho.com/podcast for all available episodes. We're on Spotify, Apple, Google, and a few other listening platforms. Make sure you subscribe, like, and share on whatever platform you utilize. Thanks again for listening, and until next time, take care.